All right, wonderful. So, listen, I am so glad to be here talking to all of you about my very most favorite thing, and that is plant-based nutrition and kidney disease. Because I've worked with kidney disease my entire career. I am passionate about helping people who have either failing kidneys or failed kidneys be the healthiest that they can possibly be. And so that is what we're going to talk about today. Now, I'm going to go ahead and share my screen. So here we are. And the title of this talk is Plant-Based Kidney Protection Made Easy, Whole Patient Strategies, because we're going to talk about who you are as a whole person from CKD, which is not on dialysis, all the way to dialysis. Okay. So let's talk about some objectives. So today, like I said, we're going to carry the theme of total body health resulting from plant-based nutrition. And the reason I say that is because just because you're struggling with your kidneys, you cannot forget the rest of your body. We're going to provide truth about nutrition and kidney disease that you may not have heard from your doctor. We're going to take a walk through history. The reason I'm doing this is because sometimes people say, well, why wasn't I ever told this? I'm going to explain to you why you were never told this. Help you understand important topics of nutrition and chronic kidney disease from pre-dialysis all the way to end stage and dialysis. And then we'll talk about simple tips, things that you can do right now to improve your health and help you set yourself up for success. Okay, so let's start at the beginning with whole food plant-based nutrition. So the reason that we're starting here is because this is highly evidence-based. If you've been in this, following a lot of the speakers throughout these presentations in this whole seminar series, you know that by now. There's long-term overwhelming research and epidemiology. If you look at groups of people who are healthy and live really long lives, most of those, all of those really eat a form of plant-based nutrition. Okay, so with that, let's just talk about some of the things that surround kidney disease, because what I want you to walk away from this slide with is that plant-based nutrition is helpful for all the other things that you may have going on. And also that, a lot of times people think, oh, well, it's in some way deficient. And that's not the case. I think you'll see after this, it's actually superior. So if you look at obesity, and all this information I'm giving you is from this one paper. It's an update for physicians on plant-based diets. For obesity, what it looked at was 87 published studies. So, and if I talk about, if I use the term vegan or vegetarian throughout this entire presentation, it's because the study I'm referencing uses that. I like to use whole food plant-based because there's a big difference in, say, a junk food vegan diet versus a whole food plant-based diet. So I'll just say that up front. But in this study, vegan or vegetarian diets were highly effective for weight loss. A vegan diet caused more calories to be burned after meals, in contrast to non-vegan diets, which may cause fewer calories to be burned because the food would be stored as fat. So there's a positive association between meat consumption and obesity that they pulled from these 87 studies. For diabetes, they looked at the Adventist health studies. The Adventist health studies are, it's a group of studies where they followed the Seventh-day Adventists. This is a religious group where plant-based nutrition is part of their religion. And they found that vegetarians have approximately half the risk of developing diabetes as non-vegetarians. Heart disease. This is one comorbidity I'm actually going to really go into at the end, towards the end of this presentation, because what you need to know is that if you're a kidney patient, you're a heart patient. Most people with kidney disease actually die of some kind of heart complication. If you look at the Lifestyle Heart Trials by Dean Ornish, he showed not only that you can stop hold in its tracks atherosclerosis, the laying down of plaque in the arterial walls, but that it can actually regress. It can actually get better. And then the Lion Diet heart study showed, it looked at Mediterranean type diets using fruits, vegetables as the base. And that these are much more heart healthy. There was a 73% decrease in coronary events and a 70% decrease in all-cause mortality. And then high blood pressure. is pretty nailed down that a plant-based diet is going to improve blood pressure. Please note that diabetes and high blood pressure are the two main causes of kidney disease. So we definitely want to do something about those. And for high blood pressure, in 2010, the Dietary Guideline Advisory Committee actually performed a literature review, and they found that vegetarian diets were associated with lower systolic pressure and lower diastolic pressure. So all that just to give you a bit of a background. Now, here we are at kidney disease. Does plant-based nutrition help those with kidney disease? Yes. So I'm going to show you how that is. All right. Now, what we're going to do is we're going to start with pre-dialysis, and I'm going to follow the same pattern with dialysis. I want to show you case studies of actual patients where plant-based nutrition helped them. Then we're going to talk about the history of plant-based nutrition in pre-dialysis, because that's very important, and then the research behind that, behind why it's important and why it helps now. So a case study, a history, and a research. You'll see what I'm talking about. Okay, so let's talk about some patients. Let's give you some hope here. So this was the very first patient I ever worked with in the pre-ESRD space. I started my career in kidney disease straight out of school in dialysis. But when I was in dialysis, I kept thinking, you know, my gosh, I'm from the South. I'm from just south of Memphis, Tennessee, and South Haven, Mississippi. And I was noticing, like in Memphis, dialysis centers are popping up on every corner. I mean, it's like a Walgreens. They're everywhere. And I thought, we've got to do something different. We've got to help patients. And so I was working on my master's degree, and I began doing all my research in this area. And I noticed that over in Europe, they were doing things very differently. They were putting patients on low protein or very low protein diets, supplementing with keto analogs, which we'll talk about what that is. And the patients were getting better. Their GFRs were getting better. So I said, this man heard me speak, the son of this elderly man, and he said, I want you to work with my dad. Okay, so if you look at this graph, I started working with his dad in March of 2012, and you're going to see the line shoot straight up. Okay, what this is the man's glomerular filtration rate. What does that mean? That is a lab that tells us how well your kidneys are working. You want that to be a higher number. You want that to get better. So I had hoped when I began working with this man that we could at least just keep him stable. His GFR was 15. That is a time when most doctors want to start dialysis. And in fact, his doctors wanted to start dialysis. But he said, you know what? He told his doctors, I'm not going to do that. I'm going to work with this girl that I found. So here we are. He's working with me. His GFR got better. It went all the way up to 25. And you'll see that kind of went up and down and up and down. This is something you might expect if the GFR is that far along, if it's that far gone. We didn't have keto analogs at this time. They weren't even available in the United States. So we dropped his protein very low, and we supplemented back with amino acids. We kept this man off of dialysis for 16 months. Now, that may not seem like very long to you, but he was 84 years old, and he wanted to live his life. And we did that with diet alone. There was no medication changes at all. Also, if you notice here, his albumin level got better. What does that mean? Albumin, a lot of dietitians don't like albumin. They say, oh, it's not a good marker of nutritional status, but it's what we've got. So it is a marker of nutritional status, but it's also a marker of like mortality and health. You'll see that when we began to work together, it got better. It did eventually go down some, but it only went down to 3.5. So we kept him nutritionally sound so that when he did start dialysis, he was stronger, because the first 90 days of dialysis are critical for patients. You've got to be strong, physically strong, nutritionally strong to start dialysis. I have had patients who didn't work with dietitians pre-dialysis start dialysis with an albumin of down in the 2s, and that's very dangerous. So we not only kept him off dialysis longer, but we helped him start dialysis better. Okay, here's a new one. This is a younger man. He had IgA nephropathy, which typically will affect younger people. It was a college student. His mother found me. I was taking a spin class in a gym, and the instructor knew what I did for a living, and she was talking to me about it. And this lady heard, and she looked at me and she said, would you please help my son? This is how desperate people are for help with kidney disease, and they're not finding it. And I said, absolutely. So I started working with her son. After only 2 months, his serum creatinine improved. Look at how well it improved. So serum creatinine is another marker of kidney function. It's what we use to actually calculate the GFR. You want the serum creatinine to be lower. And look at his, it dropped all the way down from almost 4.5. Look at this, all the way down to 3 in just 2 months. Nutrition changes alone. Okay, this is another patient. This is traditional hypertension. Remember, I said that hypertension and diabetes are the two main causes of kidney disease. And this patient went from an eGFR of stage 3. So if you know about kidney disease, it goes in stages: stage 1, 2, 3, 4, 5. Once you get to 5, you're almost to dialysis. 5D is dialysis. This patient was a stage 3, and they improved to a stage 2 in only 2 months by eating a whole food, plant-based, low-protein diet. So here's some other case studies. This is a lupus nephritis. So I'm trying to show you a lot of different people with different causes of kidney disease, so you know that this really works for everyone. Lupus nephritis, when she started with me, it was in February of 2022. By June, the GFR went up from 39 to 54. One that we called an unknown cause, probably this patient needed a biopsy, but either way, from April to June, the GFR improved from 38 to 47. So I love these studies because it makes me excited, because these patients get hope. They get hope that maybe they can miss the dialysis chair. So the question you may be asking yourself, which a lot of patients do, is, okay, well, why did my doctor tell me there was nothing I can do? Now, there are some nephrologists across the country that actually do refer to dietitians and do understand the nutritional aspect of this, but some of them do not. And they'll just say, well, there's really nothing you can do. I'm going to put you on an ACE inhibitor or an angiotensin receptor blocker, and we'll just wait for dialysis. And I'm going to tell you, do not accept that. But the reason, I'm going to show you why. So we got to go into some history here. Okay. So before 1972, if your kidneys failed, that was just it. In 1972, Congress in the United States passed a law called the Entitlement Law, where everyone could now get dialysis and Medicare would pay for it. Before that, we had to do something different. Guess what they did? They treated the patients with diet. And so this you'll see it goes all the way back to 1918, 1963, 1964. These doctors are well known for treating kidney disease with diet. Every one of these diets were low in protein and de-emphasized animal protein. The very thing that I'm doing, and some of my colleagues who are working in the pre-ESRD space are doing now. This is why you need to be referred to a dietitian. All showed a decrease in uremic symptoms. All that means, uremic symptoms, when your kidneys begin to fail, your kidneys filter out toxins. So when they begin to fail, they're not filtering out toxins anymore. And so they call them uremic toxins. Your body's getting toxic and it gives you symptoms. All of these worked. Okay, so what happened? Why is this not being taught now? And now we have to go to the MDRD trial. So the MDRD trial took place from 1989 to 1993. This trial still haunts us today, because what the trial supposedly showed was that a low protein diet produced a worse outcome, or inconclusive at best, that a low protein diet did not help patients. The problem is this trial was not very well structured. There were many issues, and I'm going to talk about some of those. So the results of the MDRD trial were based on prescribed protein intake rather than actual protein intake. Well, any dietitian in the world will tell you, sometimes I prescribe things or I ask patients to do things and they don't do it. Just because it was prescribed doesn't mean the patient did it. Enrolled patients didn't have to exhibit evidence of progressive renal failure. So if we're trying to slow progression, they need to exhibit evidence of progressive renal failure. Okay, ACE inhibitors are commonly used to slow progression of kidney disease, but they can mask the benefits of diet. So they would need to be really controlled in the study to kind of stay on top of them to see actually what they were doing in these patients. But these patients were treated with them in a very unregulated fashion. Study group B had no control group, which is a problem in research. A rapid decline in the GFR in study group A was followed by slowed progression. So really the trial wasn't long enough. It needed to be longer to evaluate the study group A. And then also the regimens failed to maintain adequate calorie intake. So if you don't maintain adequate calorie intake, you will use the protein you do take in for energy, and that can put you in a malnourished state. So let's talk about more recent research then. If the MDRD trial is not what we want to go by, what do we want to go by? So this is a great study by Brunori and colleagues. They looked at elderly patients. So they're greater than 70 years old, and they had very low GFRs. Remember, I told you the one patient I worked with had a GFR of 15. They were ready to start dialysis at 15. These people had a GFR of 5 to 7. So in this study, they were either randomly assigned to a very low protein vegan diet that was supplemented with keto acids or keto analogs. All right, let me tell you what that is now. A keto analog, protein is made of amino acids. You have 3 macronutrients: carbohydrate, protein, and fat. Most people know that. Of those 3, the only one that has nitrogen is protein. And you have to filter, your kidneys have to filter nitrogen waste when you break down protein. That is why we back up on protein. The problem is if you back too low, you can become protein malnourished. So what do? We give back amino acids that don't have nitrogen. That is a keto analog. It is an amino acid that doesn't have nitrogen. That's what they did for these patients. And so the 2 groups were, they were put on a low protein vegan diet supplemented with keto acids, or they were put on dialysis without dietary intervention. And what they found was that the death rates between the 2 were not statistically significant. And so what the authors concluded is that this diet is a safe method for postponing dialysis, especially in someone older. Dialysis is hard. Ree and colleagues, this was a meta-analysis. What is a meta-analysis? It's just where the researchers pull together a bunch of studies and compare all the results. So they pulled together 16 trials. And here's what they concluded. A low protein diet from these 16 trials enhances the conservative management of non-dialysis dependent chronic kidney disease. So it maintains the non-dialysis patient where they are, and it's considered a potential option for CKD patients who want to avoid or defer dialysis initiation to slow down progression. So you're going to slow progression, you're going to put off that dialysis chair while the risk of protein energy wasting and cachexia, that's just malnutrition, remains minimal. What they're saying is a low protein plant-based diet slows progression to the dialysis chair and will keep you well nourished. That's what they're saying. Here's where we are though. The unfortunate truth for pre-dialysis patients. So if you are a pre-dialysis patient, I want you to be activated in your care, and I want you to be your best advocate and ask for help, because here's why. 48% of patient participants had never seen a registered dietitian in this study of pre-dialysis patients. Nearly half of the patients in this study reported that their doctor never even suggested it. So if your doctor doesn't suggest it, you suggest it. Most participants agree that medical nutrition therapy is important for preventing progression of kidney disease. The patients know this is important. They have to ask that their doctor get them to somebody to get some help. Patients are interested in being referred to a registered dietitian nutritionist. And most patients, 63%, either agreed or strongly agreed that they can easily attend another appointment to see a dietitian. And the reason that's important is because some people will say, oh, well, they don't want to go to another doctor appointment. But these patients said, yes, I do. I want to go see a dietitian. In fact, and most dietitians nowadays, they work virtually anyway. If they're in the pre-ESRD space, they're going to work with you via Zoom or something like that. Okay, that was pre-dialysis. Let's step into dialysis. If you're a dialysis patient, this is for you. Can plant-based nutrition still help you? Same thing. We're going to follow that same pattern to keep it uniform. I'm going to go with the case study. I'm going to go with the history, and then I'm going to tell you what the research is saying. Case studies. Okay. Can you eat a plant-based diet on dialysis? Yes. So this is an end-stage renal disease male. This is what his diet consisted of. It was like fruits, vegetables, nuts, seeds, and grains. He made sure they were always unrefined. That means not processed. So he wasn't eating processed junk food with artificial coloring and flavoring. He was eating whole plant foods. He only ate about 2 meals a day. He was very active. He climbed, he walked, he swam, he loved the outdoors. He's devoted to his prayer life. And just he kept a very positive outlook on his chronic condition, on his disease, which is also super important. Along with nutrition, is just have that positive outlook. His medications, some of you on dialysis will recognize this. He was on Epogen, he was on a phosphate binder, but the rest of his medications, he had replaced with herbal formulas and natural means. If you ever want to do something like that, make sure you work with your doctor or your dietitian before you do it. He was dialyzed for 3 times a week for 3 to 5 hours per treatment. So he was an in-center dialysis patient. But he said that unlike all the other people around him on dialysis after treatment, he was ready to go without any sluggishness. I firmly believe it's because of the way that he ate. So people say, oh, well, I can't do that. My phosphorus will go too high. My potassium will go too high. I'll become malnourished. Here's his labs. His calcium is perfect. Phosphorus, potassium, perfect. Albumin, perfect. Phosphorus from plant-based sources is much more poorly absorbed. We're going to go over that, but everything, he had the most perfect labs. So ESRD female, same thing. She ate a whole food plant-based diet. One time she did have an elevated potassium, and what she did, the reason that it got high is because she was doing smoothies with high potassium fruits and vegetables in there. So anytime if you're doing like a juice or a smoothie, you're going to grind that fiber cell. And so you'll much more readily absorb that potassium. So that is why her potassium went high. Once she pulled out those high potassium fruits and vegetables out of the smoothie, she was fine. She did gentle exercise like yoga. And she was on Epogen. She was also on IV vitamin D, and she was on phosphate binders. She initially dialyzed 3 times a week, but was able to decrease to twice weekly because her creatinine level was low. So, and that was, I believe, had a lot to do with her diet. What did her labs look like? Phosphorus perfect, potassium perfect, albumin perfect, and her creatinine actually got better. It decreased from 10.81 to 7.33 when she switched to a whole food plant-based diet on dialysis. Okay. So here we are again. You may be saying, well, why did my doctor or dietitian tell me to eat white bread and meat? Okay, those habits die hard. So again, now we've got to step back into history for me to explain that to you. Historical dialysis is heavily focused on protein quality and protein deficiency. It focuses heavily on just the kidneys. It forgets the whole patient. Some people are still going by the outdated KDOQI guidelines. KDOQI is just the guidelines for America for kidney disease is all that is. And so with that, they're following the outdated quote renal diet. There is no renal diet anymore. It should be individualized to every person. Okay, so let's start with that protein quality, the historical meat focus. Okay, why is that there? Historically, protein has been categorized, like, how do I tell if a protein's good? Well, we're going to go with high biological value protein. That is so antiquated. That phrase, I do not love that phrase, high biological value. How did they come up with that? So high biological value came from these nitrogen balance studies. So, but these nitrogen balance studies aren't really very accurate because the studies did not consider varying calorie intakes. So they're very confounded. Confounded means like very confused because the remember I said earlier that if you don't eat enough calories, you will use the protein you eat as energy. You have to eat enough calories to preserve that protein. So that didn't work. Also, there was a study with intensive care unit patients in 2022. And one thing that the researchers there walked away with from their study and from previous studies is not taking into account the calorie intake, but also total energy expenditure. So some people have a higher metabolism. They're going to expend calories more than others. Today, you might expend more calories than you do tomorrow, right? So even though you can meticulously try to use nitrogen balance studies to evaluate protein, these researchers concluded that such errors like in energy expenditure and calorie intake are likely even in our own studies. So they're saying that this research is really, there's too many errors even in our own study. And then if we were even to use nitrogen balance studies, there was a meta-analysis that showed there was no significant difference between animal protein, vegetable protein, or mixed sources. And that's because if you eat a variety of plants, you still get all the amino acids you need. If you eat animal protein, you may get it in one fell swoop, but if you eat a variety, you're still going to get it. All right, so nitrogen balance has kind of gone to the side a little bit. It's still there a little bit. And so people have opted now for something called protein digestibility corrected amino acid scores. You don't have to remember that long name, PDCAA. How does this measure protein quality? So what we're doing is we're giving protein a grade by these things I'm describing to you. So this is the newer preferred method. The first thing, there's 3 ways that it grades a protein. It looks at its essential amino acid composition. Okay. Well, I just said, of course, in this scale, animal protein is going to score higher because it has all the essential amino acids. But if you eat a variety of plant foods, you're still going to get all the essential amino acids. Digestibility. So this is really skewed because they use fecal or stool studies to determine digestibility. The problem is that protein is absorbed further up in the GI tract. So if you're using stool, right, you're way down in the GI tract. But if you're up where it's actually being absorbed in the ileum, that's way up in the small intestines, then really you need to be looking at ileal studies. And there is a protein scoring test that does that called Dialysis, but you'll never see it because it's only used in research. So digestibility really doesn't make sense either. And then this is really strange. The PDCAAs are based on the requirement of a 2 to 5 year old child. Okay. The first problem with that is when we're looking at adults, you're not a 2 to 5 year old child. The second problem with that is that the study that was performed on these 2 to 5 year old children were malnourished children recovering from malnutrition. So that really kind of skews that. And even if they weren't recovering from malnutrition, the most demanding age nutritionally is 2 to 5 years of age. So it skews the scoring of these amino acids. 1 is the best possible score, and I think I've already explained everything else on that slide. What am I saying? What is my point here? There are major issues with high biological value protein and PDCAAs, but this is still the story in dialysis. You're going to be told, oh, you're going to become protein malnourished. Oh, you've got to get more protein. You do lose protein in the dialysis machine. If you're on hemodialysis or especially peritoneal dialysis, you are going to lose protein through your treatment. But you can easily replace that, as we saw in the 2 case studies, with plant proteins, as long as you're eating enough and you're eating a varied diet. Both of these 2 ways that they score protein that makes it where you feel like you have to have animal protein in your diet are based on single foods and not a mixed diet. They're over-restricted diets. If you're eating an over-restricted diet, you're going to have deficiencies, whether you're eating animal or plant-based. So the historical focus on protein quality to improve nutrition status is overemphasized, and it's really only part of the picture when it comes to dialysis patients. So speaking of nutrient deficiency, Kadoki presents the historical dialysis diet. So old Kadoki guidelines. This is historical because thankfully it's been changed. But the old Kadoki guidelines forgot the whole patient. If you're a dialysis patient, you still have a liver, you still have a heart, you have a brain, you have arteries and veins. And so if you're eating this deficient diet, high in meat, low in fiber, low in vitamins and minerals, it's not a good thing. There were strict potassium and phosphorus restrictions that did not consider overall health in this historical diet. But it's very hard to change mindsets, especially for someone who has been in dialysis a really long time. So if your dietitian or your doctor has been there a really long time and they're still kind of saying the same things, it's because they're still back on the historical Kadoki diet. Again, you be your best advocate. You be activated in your care. You are the most important team member on your healthcare team. You know your body better than anyone else. So the outdated renal diet, this is what it looked like. We would say, oh, you can only eat white bread, no whole grains, because whole grains are high in phosphorus. The problem is that phosphorus is bound in phytate, so you're not even going to absorb it that well. So you can eat whole grains. Lots of animal protein. Well, we just went through a whole discussion about why that is not necessary. No beans, no peas, same thing. High in phosphorus, also high in potassium, but the fiber in those helps decrease the absorption of both potassium and phosphorus. And there is no blanket number for phosphorus and potassium for a restriction. And I'm going to show you why in a minute. Minimal fruit. You can eat fruit. No high potassium vegetables. If you run a high potassium, yes, you may need to back up on some of the high potassium vegetables. If you don't, you can eat some of those high potassium vegetables. Everybody is different. If you're on peritoneal dialysis, likely your potassium will go low. So you don't even have a potassium restrictions more times than not on peritoneal dialysis. And fiber is not even considered in this outdated diet, and it should be. So what are the new Kadoki guidelines? Old Kadoki guidelines, potassium for every single patient, 40 milligrams per kilogram of ideal body weight or standard body weight. Now it's individualized per your lab. If your lab is perfect every month and you're eating high potassium fruits and vegetables, continue on. Phosphorus, 800 to 1,000 milligrams per patient. It was across the board. That's what we did. Now, Kadoki guidelines in 2020 say this should be individualized per your lab. If your lab is running fine, then you can have more phosphorus. If not, then maybe you need to back up a little bit. But remember that the phosphorus in plant-based foods is not going to be as well absorbed. All right. So I think I laid a really strong base for where we were, both in pre-dialysis and dialysis, and where we need to go. So let's look at better science for better recommendations. Now I want you to tune in. This is what we need you to do to be healthy wherever you are in your kidney disease journey. We're going to look at protein, acid-base balance, inflammation, the gut-kidney axis, phosphorus, potassium, and we'll end with cardiovascular disease. Protein. Pre-dialysis, we've said it, low protein, dialysis, increased protein. But remember, these proteins can come from a plant source. And pre-dialysis, they should come from a plant source. Think low protein sourced from plants. Sometimes you may need very low protein if you are very late stage kidney disease. If you're nearing dialysis, very low protein supplemented back with keto analogs. Why is this? We want to decrease nitrogen waste. Remember that protein is the only macronutrient that has nitrogen, so we've got to decrease the nitrogen waste. With that, we'll lessen the load on the kidneys and we'll lessen the intraglomerular pressure. So the glomerulus is a part of your kidney, and we want the pressure on that to be low. If you think about your kidneys pre-ESRD, we want those kidneys to rest. If you have a brand new car, you can drive it from Mississippi to California and you're fine. But if you have an older car, you don't want to wear it out like that. You want it to rest. So that's what we were thinking about with your kidneys. We want them to rest. Okay, so the University of Utah School of Medicine said that for every 33% increase of plant protein in a CKD, I'm talking pre-ESRD, patients die a 23% lower risk of mortality ensues. And why is that? Because we are looking at the whole patient. We know that plant protein helps with all the other comorbidities, blood pressure, diabetes, cardiovascular disease. It helps with all those things. The whole rest of your body, besides your kidneys, it helps with that too. So that's why we're going to see that risk of mortality decline. So if you think about the type of protein, what comes in the package, right? So if you're talking about plant-based protein, it is packaged with zero cholesterol, no saturated fat, unless you're eating tropical oils. It's very alkaline, which we're going to talk about acid-base balance. It's full of antioxidants, which is going to lower your inflammation. It's full of fiber, which is also going to lower inflammation and help your gut be healthy. There's going to be less waste. Remember, your kidneys filter out waste. You're not going to produce as much if you don't eat as much. The phosphorus is poorly absorbed and there's no additives. If you're looking at animal-based protein, it is going to have cholesterol. It is going to have saturated fat. It is very acidotic. It is void of antioxidants. There's no fiber. It's going to cause a high uremic waste. The phosphorus is much better absorbed. And on top of that, the phosphorus is naturally better absorbed in animal sources, but food manufacturers inject meat and animal protein with potassium and phosphorus additives as a preservative, and those are almost 100% absorbed. Okay, let's look at dialysis. Can we meet the protein requirements with plants? Well, we showed that in our case studies, right? So we want to know now, can a dialysis patient remain well nourished eating plant protein? We want to know now, what does the science say about that? So this is a mini review. This is on dialysis patients. And I keep going back to this because if you go back to your dialysis center, you may hear something like you're going to become protein malnourished. So I want you to be armed with information to say, no, I'm not. Okay. If you eat a whole plant-based diet, you may have to find a dietitian to help you do that. But this is a hemodialysis patient. So it was 2 studies. They reviewed vegetarian dialysis patients. So they were eating plant-based protein, but it was still enough protein that they needed in a day. So a dialysis patient, when a dietitian calculates your protein needs, they're going to calculate 1.2 to 1.25 grams per kilogram of protein a day. That calculation still stands. You're just getting the protein from a different source. You're getting it from plants and not animals. So these patients in this study achieved the nutrition requirements without signs of undernutrition. And what they came away with was that the amino acid variability, whether it comes from a plant or an animal, is trivial as long as the calorie needs are met and the diet has variety. Everything we've been saying, you've got to eat enough calories to preserve the protein so you don't use it as energy. You need to eat a varied diet. And if you do those 2 things, it doesn't matter where the protein's coming from as long as you're meeting your needs. You don't have to eat animal protein to meet your needs. This is another study. It was the nutritional status of vegetarians on maintenance hemodialysis. So they compared 19 vegetarian to 299 non-vegetarian, which shows you that most people on dialysis are not vegetarian, but you still can be. And they looked at different biometrics. This one was kind of cool. It looked at like body mass index, mid-arm muscle circumference. So that's like if you measure the middle of their arm, you're looking at like how much muscle is there. And they found that mid-arm muscle circumference was a little bit lower in vegetarians, but subjective global assessment, that's just a malnutrition assessment. Hand grip strength, how strong was the hand grip, and function of daily activities were similar in vegetarians and non-vegetarians. So they weren't weaker. They still had the same amount of strength. If you look at the albumin, the differences are minuscule. The non-vegetarians a little bit higher, but barely, by 0.2. If you look at potassium, same thing, 0.2 difference. In vegetarians, the phosphorus was lower, and the parathyroid hormone was lower. So that all has to do with the bone mineral metabolism. So the people who were vegetarian actually had better bone mineral metabolism numbers. Okay, for all you peritoneal dialysis patients out there, this is plant-based diets and peritoneal dialysis. It was a review by Liebman and Dr. Joshi, who I'm a huge fan of. He wrote the preface to my newest book, which we'll talk about at the end of this presentation. But he is a nephrologist that does understand plant-based nutrition, based out of New York. I absolutely love him and shout his praises. But anyway, okay, so they looked at 844 peritoneal dialysis patients. So the ones that had the most protein from plants had higher albumin levels despite a lower protein intake. How could that be? They had to explain it. Well, the average albumin loss across the membrane. So whenever you do a dialysis exchange on PD, you're going to lose about 5 to 8 grams of protein per day. So normally, this would be compensated by liver synthesis. So your liver makes albumin. It makes proteins, okay? If you are in a state, let's say you get the flu, your liver's not going to make as much albumin. It's going to make these anti-inflammatory proteins instead to fight the flu, because it says, hey, albumin, you're not as important right now. We've got to make proteins to fight this infection. Okay. Now, let's talk about when you eat animal protein, it is inflammatory. So the body thinks we're in an inflammatory state. So I need to make proteins to fight that inflammation. So it's going to prefer those proteins over albumin. That is exactly what they saw in this study. They said normally that the liver would make albumin if it loses it across the PD membrane, but it was unless it's suppressed by inflammation and chronic acidosis. So those people who were eating plant proteins had less inflammation, less acidosis, and so their liver was able to make that albumin to compensate for what was lost across that PD exchange, which I think is pretty fascinating. Which brings us to acid-base balance. Did you know that your kidneys maintain your blood at the right pH? The kidneys do so many things. So we've already talked about that they filter out waste. They also maintain acid-base balance. They do this by secreting hydrogen ions. So you're going to urinate out hydrogen ions and you're going to reabsorb bicarbonate. Hydrogen is acid, bicarbonate is alkaline. This whole process begins to get impaired at a GFR of 40 to 50. So that is very early on, like stage 3A or worse. So very early on in the process of kidney disease, this acid-base balance can get out of whack. So we really need to get on top of it quick. Okay. Pre-dialysis, what are you going to do about an acidotic state? You're just going to eat a plant-based diet. And if a dietitian looks at your labs, she'll look at your bicarbonate level. And if your bicarbonate level is not where we want it to be, then we can do something as simple as just giving you a teaspoon of baking soda in water. And now we get you back into an alkaline state. Very simple. Dialysis is a little bit harder because the kidneys have completely failed. So there is bicarbonate, like let's say we'll do hemodialysis. They put bicarbonate through the machine. As your blood's going through the machine, they're putting bicarbonate in there, right? But what I always tell dialysis patients is this: help the dialysis machine. Don't just do whatever and then expect the dialysis machine to take care of everything. Help it. So if you ate a more alkaline diet, now you're helping that dialysis machine keep your bicarbonate in the place that we want it to be. Why do we even care? Okay, if you are in a more acid state, your muscles can waste. You'll lose muscle protein, your muscles will waste. Destruction of bone and bone disease. We already know kidney patients are at risk for bone disease. We don't want that. Decreased albumin synthesis, what we just talked about in that study. Your liver won't make enough albumin. Increased rate of progression of chronic kidney disease. We don't want you to progress. We don't want you going to the dialysis chair. We want you to stay away from that dialysis chair. Stimulation of inflammation, which we're going to talk about inflammation, and impaired insulin secretion and responsiveness, which is really bad for people with diabetes. We want you to be very insulin sensitive. Okay, so how do you know? You're saying, okay, well, then how do I know if my diet is acid or alkaline? Well, there's an easy way to know. There's something called potential renal acid load, PRAL. What this is telling us is if I have a food, when I take it into my body, does it produce an acid state or an alkaline state? It doesn't matter what the food is outside the body. So if you take a lemon outside the body, right, it's acid. But when you put it inside the body, it's alkaline. So we have to look at the potential renal acid load to know what the food's going to do inside the body. And so here we go, potential renal acid load of certain foods. You want this to be a low number. You don't want the food to produce an acid load. So you want a low potential renal acid load. Look at fruits and vegetables. They have a negative number. Milk and whey products, a plus product, but look at all the animal protein, a very high number. So what that's telling you is you need to eat plant protein, not animal protein, to have an alkaline state in your body. Okay. Pre-ESRD, pre-dialysis, does lowering acid slow progression? Yes. Why? Because protein, particularly animal protein, is the principal source of acid generation. Eating an acid-forming diet increases certain hormones. So when your body is acidotic, it's going to increase certain hormones like angiotensin 2, aldosterone, endothelin. These hormones are the ones, remember I told you about that the doctors many times will say, I'm just going to give you an ACE inhibitor or an angiotensin receptor blocker and send you on your way. Those drugs work on these hormones, trying to keep these hormones, stopping them from doing what they should be doing. So if you eat an acid-forming diet, you are bolstering these hormones. Short term, these hormones will help excrete acid, but long term, they're going to worsen kidney function. Okay, now let's talk about you, dialysis patient in particular. Acidosis, same thing. Increased catabolism, decreasing muscle mass. It makes your bone mineral metabolism worse. It's going to cause calcium to go from inside the bone to outside the bone. It's going to increase your parathyroid hormone, which you don't want. You want a normal parathyroid hormone. It's going to alter the inotropic state of the heart. What does that mean? It's how your heart contracts. You don't want that altered unless a doctor specifically gives you a medicine to alter that because you have a problem. But you don't want to be altering that because of your diet or because you're in an acid state. It triggers mechanisms underlying malnutrition, inflammation, atherosclerosis. This is called the uremic phenotype. It's just this phenomenon that we see in dialysis patients where these three things go together. The malnutrition, the inflammation, and the heart disease. It's just like this one big cyclical mess. Acidosis is going to increase that, and it increases morbidity and mortality. So one thing that we really want to ask with dialysis patients is dialysis bicarbonate adequate? So this varies because it depends on where you dialyze. Theoretically, bicarbonate should be an individualized prescription. However, the reality is it's on the loop, meaning that every patient gets the same. And again, it depends on where you dialyze. It even depends on what country you dialyze in. But also, the question about, well, maybe we just give more bicarb, but the research hasn't been very clear on that. And in fact, the adoption of this practice, it still demands more conclusive studies, because if you put someone in metabolic alkalosis, so you send them the other way from acidosis to alkalosis, that's also dangerous. So there is an argument for home therapies, and I love home therapies. If you're an in-center hemodialysis patient and never considered home therapies, think about it, because it's more individualized to you. But there's also an argument for diet, like eating an alkaline diet, which is the most natural way. But for now, I'm just going to tell you again, help the dialysis machine. Eat on the more alkaline state so that the dialysis machine doesn't have to do all the work. All right, inflammation. What do you need to know? So we've gone through protein, we've gone through acid-base balance. Now what you need to know is inflammation. We've already talked a little bit about this. What is inflammation? So if you think about, if I cut an apple and it turns brown, that is a picture of inflammation. It's oxidation. That brown is oxidizing. Rust is also oxidizing. If I take a lemon and I squeeze it on that apple, that browning stops. Okay, the same thing happens inside our bodies. We have oxidants, which is this middle free radical. You can call them a free radical or an oxidant. It's the middle guy here, okay? And they're not complete. They're missing an electron. And so they begin that browning or rusting process inside of us unless we do something about it. So if you have an oxidant, what you want is an antioxidant. You want to stop this process. So the antioxidant is the friendly guy that has an extra electron. He comes along and gives it to the oxidant and stops this process. If you don't stop the process, then the oxidant will keep stealing from other healthy atoms, and then now that one's an oxidant, so it steals, and the process goes along to where it'll eventually damage DNA. This is the beginning of cancer and things such as that. You need antioxidants. You have to eat antioxidants. Also, your body can make antioxidants, but you have to eat certain things for your body to make antioxidants. So let's talk about that a little bit. If you have that process going on that I just showed you pre-dialysis, as kidney damage worsens, so does inflammation and oxidative stress. A lot of this has to do with those toxins again. Your kidneys aren't filtering them out. Your body is building up toxins, and it's becoming inflamed because it's trying to fight those toxins. This can cause premature aging and kidney fibrosis. That's scarring. So it's just scarring your kidneys, and we do not want that. Inflammation contributes to malnutrition, coronary artery calcification. So, or like damage. What that means is that you're laying down calcium in your arteries and veins, and eventually that can become blocked and you can have a heart attack. Endothelial damage is that lining, that inner lining of your arteries and veins. You want to protect that. If you're in an inflamed state, you're going to damage that, which leads to atherosclerosis. It can lead to insulin resistance, anemia, bone disease, and ultimately progression of kidney disease, which we certainly don't want. All right, now let's talk about dialysis. Inflammation in dialysis. Inflammation is a strong prognosticator of sudden death in patients with end-stage renal disease. So it's something that we need to address. I've been talking about this now for a few years, like, hey, we're not addressing this. If we know that it's an indicator of sudden death and we're trying to keep people alive on dialysis, then we need to address inflammation. The phenomenon of inflammation persists and remains an unaddressed target, unaddressed need and therapeutic agent. So I am going to address it. What contributes to inflammation in dialysis? Okay. Pre-dialysis, we talked about, is a lot of those toxins. Dialysis, the dialysis membrane in and of itself. If you are on hemodialysis and peritoneal dialysis, you're using your own peritoneal cavity. So that's more natural, but this is a foreign body. If you start dialysis with the central venous catheter, which is in the middle picture, you see there's a catheter there, and this catheter goes down and it's inside the heart, inside the body. The problem with this, why do we even have this? If you're late stage kidney disease and you don't act ahead of time to get a permanent access in your arm, that's called a fistula, and let's say you crash into the ER because all of a sudden you're holding fluid and you can't breathe and your kidneys have failed, we have to dialyze you now. And the only way to do that is to put in the central venous catheter, which is very dangerous and very inflammatory. Certain medications, and then there are certain middle and large molecules and protein bound molecules, which I'm going to talk to you about what that means. So when you go to dialysis, the dialysis machine removes toxins or certain molecules. If it is a small molecule, if it's a small toxin like urea, creatinine, no problem, removes it just fine. If it is a middle molecule, it does not remove it. So when we talk about inflammation, when your body is in a state of inflammation, it produces certain things like called cytokines, and all cytokines do is tell your body, we need more inflammatory cells. The dialysis machine will not remove these. And then there's protein bound molecules. These come from the gut, which we're going to talk about when we talk about the gut kidney axis. We don't think the dialysis machine removes these, but they are also kidney toxins. Okay. So we've got to, again, let's help the dialysis machine. If it doesn't remove inflammatory markers well, then let's keep our body from being inflamed as best as we can. If it doesn't remove protein bound molecules that our gut creates, then let's eat foods to where our gut won't create those things. How are you going to know if you're inflamed? So we talked about what inflammation is. How are you going to know? Well, there's certain things you can look at. Every month, if you're in dialysis, you get a lab report, right? And on there, it has albumin, hemoglobin, transferrin, and ferritin. Transferrin and ferritin may not be on there, but I bet your albumin and hemoglobin are, and you can ask for the others. There's also a research lab, but you're never going to get that, but we will talk a little bit about it. But if you're looking at your dialysis lab, when you get your lab report, if your albumin is low and your hemoglobin is low, then you need to ask for these other two numbers because you could be inflamed. Why is that? Because remember we said, if you're inflamed, your liver is going to say, I'm sorry, I can't produce albumin anymore because I have to produce these other inflammatory proteins, right? So your albumin is going to go low. If you're inflamed, your body is going to manage iron in a different way. Your body doesn't want a lot of iron floating around if you're inflamed, because iron feeds inflammation, one. And two, the body wants to store up iron because it feels like it's in a crisis state. So if you're inflamed, that stored up iron is represented by ferritin, the bottom number here. That's going to go high because your body's hanging on to it. The transferritin, the iron that's floating around, is going to go low because your body's going to say, we don't want iron floating around because it's going to feed infection and we need to hang on to that iron. And your hemoglobin is going to go low. So if you write these things down, and then when you get your lab report back and you look at it, you'll know, okay, I need to eat more antioxidants because I think I'm inflamed. Dietary antioxidants. So we've already talked about the typical diet for dialysis and the typical instruction for dialysis. It is missing nutrients. We need to be eating things of color, eat lots of color, eat peppers, eat blueberries, eat strawberries, eat tons of greens. All of these, if it has color, you're going to know that it has antioxidants in there. That's what you need to be eating. Pre-dialysis, the same. If you want to stop those, stop that inflammation process, cool down that inflammation, eat dietary antioxidants, eat things with color. Eat fiber. We're going to talk about how your gut can produce antioxidants, and then also help your body to make endogenous antioxidants. So one of those ways is through the gut. But right now we're going to talk about, how do you know? Okay, so we said if it has a lot of color, but how else do you know if a food has a lot of antioxidants? We can look at something called the ORAC scale. So, and you can Google this. Help me find foods high on the ORAC scale. What does that mean? The ORAC, oxygen radical absorbency capacity. You don't have to know that. What is the antioxidant capacity of this food? You want it to be a high number. So if you look at the acai berry, it's very high. Blueberries, very high. I want you to go to the middle of the screen and look at oregano. Look at how high that is. With spices, they are super high in antioxidants. And here's the thing that you can do. You can kill two birds with one stone with this. You know, if you're a kidney patient, you have high blood pressure, you need to back up on salt, right? Lower sodium. One way you can do that is by boosting up these dried spices that don't have any sodium. So not only are you lowering your sodium intake, but you're actually boosting your antioxidant intake, which is pretty amazing. But what happens is they just take, this is done in a test tube. So they'll take an oxidant and they'll take another element that is very prone to oxidation. And then they put one of these foods in there and see, how well does the acai berry protect this element prone to oxidation from the oxidant? And that's how they come up with these numbers. Your body also makes antioxidants. These antioxidants are actually more powerful. The first antioxidants that I told you about that you eat from your diet, they'll handle that oxidant, that little angry oxidant in the middle, on a one-to-one basis. These endogenous ones, they get a bunch of them all at one time. So what are your endogenous antioxidants? Glutathione peroxidase, superoxide dismutase, and catalase. You don't have to remember those names. All you have to know is there are certain foods that you need to eat to boost up these endogenous. Endogenous means made in the body, antioxidants. And here's what you need to eat. So if you'll see, it's very similar to things that you just saw on the ORAC scale, like cauliflower, broccoli, cabbage, bok choy, different fruits, teas like green tea, basil, there's your spices, parsley, sage, all those are spices, blueberries, cranberries. So these are foods that you need to make antioxidants. Okay, next topic, the gut-kidney axis. All right, so let's review. We've talked about protein, we've talked about acid-base balance, we've talked about inflammation, and now we're talking about the gut-kidney axis. So in your gut, there is a wall there, and you'll see this barrier, this intestinal barrier. The picture on the left is what you want it to look like. We believe that, especially in an end-stage renal disease patient and a dialysis patient, that the picture on the right is what it looks like. And the reason that we think this is because many times dialysis patients are fluid overload and their belly can be distended, the same as a congestive heart failure patient. And we know that congestive heart failure patients, theirs looks like this. So we don't want those junctions to be separated because you see the bacteria is leaving the gut and going to the rest of the body. So what are we going to do about this? How are we going to keep this from happening? Well, one, keep your volume, stay to your fluid restriction if you're a dialysis patient, but also pre-dialysis or dialysis, uremic toxins can affect this lining. Also, pre-dialysis or dialysis, in the inside where you see the little finger-like things on the inside of that lining, there is a mucosal layer, like a mucus. These bacteria that are escaping, they love fiber. But if you don't feed them fiber, if you don't eat fiber and it goes to your gut, they will eat mucus. So they will eat away that mucosal lining, and then again, they'll go through. Okay. Dialysis patients need fiber. Pre-dialysis patients need fiber. Everyone needs fiber. I think it's one of the most underrated nutrients in the American diet. The historical diet for dialysis patients was very low fiber. But when you don't eat fiber, either pre-dialysis or dialysis, you have an inflammatory environment now. You have lack of short-chain fatty acids and increased secondary bile acids. Let me tell you what those are. So the short-chain fatty acids are antioxidants. They will lower inflammation. Secondary bile acids are going to increase inflammation and actually make you more at risk for cardiovascular disease. So there are different things that can cause problems in the gut microbiota. So you want gut bacteria that do produce short-chain fatty acids and don't produce secondary bile acids. But there's reasons why sometimes this gets a little out of whack. One of them is certain medications you may be taking, a low fiber diet, which we've already talked about, and high animal protein. Why is this? Okay, everything you eat and it goes down and it feeds certain bacteria in the gut. And then those bacteria produce something. They produce a product. We're going to call it a metabolite. Okay, that's all that big word means. It's just, what are the bacteria in my gut producing? If you eat animal protein, the bacteria in your gut are producing kidney toxins. There's 3: trimethylamine N oxide, we're just going to call it TMAO, p-cressyl sulfate, and indoxyl sulfate. These are kidney toxins. So let's talk a little bit about TMAO. TMAO, made in the gut, cleared by the kidneys. If you are a pre-dialysis patient, TMAO is going to increase your progression towards kidney disease. This is produced as a result of, when you eat animal protein, the choline and carnitine in animal protein, when it hits the gut, the bacteria will produce something called TMAO, TMA, and the bacteria will produce TMAO. If you're a dialysis patient, it's still a problem, because even though your kidneys have failed, it's going to increase your risk of cardiovascular disease. And remember, we said that greater than 50% of people that have kidney disease, they actually die of cardiovascular disease, not the kidney disease. P-cressyl sulfate and indoxyl sulfate are very similar. Same thing. Whatever you eat, your gut is going to produce certain metabolites. If you are eating a lot of animal protein, your gut will produce 2 things called p-cressyl sulfate and indoxyl sulfate. Both of these are kidney toxins. Both of these increase the risk of overall mortality and cardiovascular disease, similar to TMAO. Plant-based diets will decrease these levels by as much as 60%. It's interesting with TMAO, they've taken people who eat completely plant-based diets, total vegans, and if you fed that person a steak, they still won't produce TMAO unless they kept eating steaks for time on end. But because they don't even have the gut bacteria in there to produce TMAO. So this is yet another reason to eat a plant-based diet, whether you're pre-ESRD or dialysis. Bone mineral metabolism. Next topic. So we're going to talk about phosphorus first. What is phosphorus? Okay, phosphorus is just a mineral in your body. You actually need phosphorus. It's actually a good thing. People on dialysis probably think it's totally bad because their dietitian probably comes to them all the time and says, your phosphorus is too high, your phosphorus is too high. Most of the time, pre-dialysis patients, you're not going to see that phosphorus level go up. There's a reason for that. But phosphorus is key for bones, teeth, and cell membranes. But your body wants to keep this your phosphorus and your calcium in balance. So why do you care? Pre-dialysis, if you have higher phosphorus levels, really it's going to be FGF23 is what you're going to see. But regardless, you still need to watch, especially junk food phosphorus. Pre-dialysis, you're going to have a faster progression. Dialysis, I'm sure you probably already know that it is going to increase your risk for bone mineral metabolism disorders. You can begin to lay phosphorus and calcium down all over your body to where you'll calcify your body. It's just really a dangerous thing in dialysis. So plant-based phosphorus is bound to something called phytate. And phytate is only like 10 to 20% absorbed. So if you're a pre-dialysis patient, if you eat a whole food plant-based diet, you're not going to hear me talk to you a lot about phosphorus because you're already doing it. If you eat a whole food plant-based diet, you solved the problem because it's only 10 to 20% absorbed if you're not eating a bunch of packaged processed foods. Animal-based diets are naturally rich in phosphorus, just in their natural state. And that phosphorus is about 40 to 60% absorbed. But again, like I said, these animal protein is injected with phosphorus additives, and that's about 90% absorbed. So if you're a pre-dialysis patient, this is going to increase your rate to progression. If you're a dialysis patient, this is where you're going to get your report card back every month, and your phosphorus is going to be high, and you're going to be getting into that deranged bone mineral metabolism. Your bones are going to become weaker, and you're going to begin to lay phosphorus down all over your body. So serum phosphate levels were significantly lower in vegetarian patients than in non-vegetarian patients on hemodialysis. So the reason that I have this in red is because, again, in your dialysis center, you're going to hear things like, oh, you can't have those beans because they're high in phosphorus. Yeah, but they're in the plant-based form. They're bound to phytate. You're not going to absorb that phosphorus. So just arming you with some information. Remember, the 2020 KDOQI guidelines, you don't have a specific phosphorus restriction. It is specific to you. It is not 800 to 1,000 milligrams. It is what is your phosphorus level. Do you know some people absorb phosphorus more than others? Some people, the dialysis machine works better to remove phosphorus than others. So it's individualized to you. So if you're eating phosphorus and your phosphorus is normal, then you're fine. If not, you may need to cut back. So this is what I was talking about with the pre-ESRD group, really both, but especially in the pre-ESRD group, your phosphorus, you may never see, like on a lab report, it being high. And the reason is because in the background, you have this thing going on called FGF23. The problem is our doctors never really draw this, but just know that it's there. So as chronic kidney disease progresses, so does this, because what it does is FGF23 causes you to urinate out more phosphorus. So it's like your body's way of trying to keep the phosphorus within normal range. The problem with it is there's a strong association between increased FGF23 and cardiovascular morbidity and mortality. There it is, heart disease again. So the phosphorus load, however much phosphorus you're eating, appears to stimulate this FGF23. So if you eat a higher percentage of plant-based protein, you're going to have a lower FGF23. Potassium. Now, this is the one that really makes people afraid, and rightly so. You know, if potassium, phosphorus is kind of a longer, slower thing. Potassium can cause heart problems really, really fast. So it is something to be careful about. It is a legitimate concern. However, I think we go about it in the wrong way. Meat is enhanced with potassium additives. And again, these are much more highly absorbed. You know, if you're eating fruits and vegetables, whatever's in there is what's in there. There's no additives. And even better, there's fiber in there. And fiber blunts the absorption of potassium. It increases transit time, so there's less absorption. Also, you need to take certain medications into consideration because sometimes it's not the diet at all that's raising your potassium. It's certain medicines that you may be taking. But this is pretty interesting. So there was a study that looked at dietary potassium intake and mortality in hemodialysis patients. And so they identified the top 10 sources of dietary potassium in these patients. And what they saw, this is what they saw: beef, chicken, Mexican food, hamburgers. Then we get to legumes and fresh fruits and juices and things like that. So like I said, these things are enhanced. They are laced with potassium additives, and they are actually what people are eating that's driving their potassium up. But practitioners always want to run to the fruits and the vegetables because of that historical KDOQI dialysis diet. Here, I'm just giving you an example of like chicken versus chickpeas and potassium amounts there. So you can just look at those and realize that it's really not that different. And you have the fiber binding the potassium in those plant-based sources. What about non-nutritional causes of hyperpotassium? So a lot of times when someone has a high potassium, they want to run to the diet every time. But did you know that if you are in that acidotic state, remember acid-base balance, if your body's in an acid state, I'm going to go over this on the next slide, your potassium will be higher. Same with high serum glucose. Certain medications, if you are taking an ACE or an ARB, so those are like things that end in pril or artin, those will raise potassium levels. Certain diuretics raise potassium levels. So that may be something you want to ask your doctor. Do any of my medications that I take, do they cause my potassium to be high? If you are in a malnourished starvation state, if you have chronic constipation, your body will reabsorb that potassium from the stool. If you have an infection, if you have a GI bleed, a blood transfusion, all these things can cause high potassium. So before we run to diet first and begin to stop eating fruits and vegetables, which you need, let's look at some of these other things. And so what is the relationship with acidosis? You'll begin to see that all these things go together, right? Animal protein causes your body to have to get rid of nitrogen waste. It causes your body to be more acidotic. It causes your body to be more inflamed. It doesn't have fiber, which helps the gut. And if you're acidotic, now you've got a potassium problem. So do you see how this plant-based, I'm talking about your whole body, a whole food plant-based diet affects all of these things. Potential renal acid load. Okay, so we've already talked about this, but if you are in an acid state, potassium likes to be inside the cell. But if your body is acidotic, it will cause that potassium to go outside the cell into the blood and raise potassium levels. So this is another reason why you need to pay attention to that potential renal acid load. There are a few cautions with potassium. Remember, we talked about the very first, the case study of the dialysis patient who had that one high potassium is because she was grinding and using high potassium fruits and vegetables and smoothies. That can create problems. Same with juices. Another thing that you never want to do is use a salt substitute, like no salt, light salt, anything like that, because instead of those being sodium chloride, they are potassium chloride. So what are we going to do instead? We're going to go back to those spices that are going to lower your inflammation level without salt. That's what we'll do for that. Okay. 2020 guidelines. Again, remember this has been updated. Potassium, same thing. It is individualized to you. If you are a peritoneal dialysis patient, you likely don't have a potassium restriction. If you're a hemodialysis patient, you may, or you may not. Your potassium may run low. If you're a pre-dialysis patient, most likely you don't have a potassium restriction. As you move along, if you're late stage pre-dialysis, you may have a potassium restriction. There is no blanket number. Work with the dietitian and figure out what is right for you. All right. Now, I do want to talk about, I could talk to y'all about all the comorbidities that go along with chronic kidney disease. Probably if I had to pick the first one's going to be heart disease. If I had to pick the second, probably be hypertension. But if you'll just eat a plant-based diet and lower your salt intake, you'll be good on hypertension. But this one, because I tell every patient I work with, if you're a kidney patient, you're a heart patient, because cardiovascular disease accounts for 40 to 50% of deaths in patients with chronic kidney disease. So I want you to be careful with your heart if you're a kidney patient, okay? All the things we've talked about. Fiber, a healthy gut, a plant-based diet, antioxidants, lowering inflammation, low acid, high bicarb, all those things also help with heart disease, the whole patient. We're talking about the whole patient. So traditional causes of heart disease, hypertension, limit salt, plant-based diet. Diabetes, there's a strong association with both chronic kidney disease and cardiovascular disease, but this is a more of a traditional cause of cardiovascular disease in kidney patients. And then dyslipidemia. So high LDL cholesterol, low HDL, high total cholesterol, laying down that fat inside the arteries and veins. That traditional, you've probably heard of it a million times. You've probably heard of it in this conference and this whole series. Those are traditional causes, and they still apply to you as a kidney patient. However, There are non-traditional causes that are very specific to kidney patients. One is high potassium levels. High potassium levels do interfere with the electrical signaling of the heart. So when I talk to you about potassium, yes, still be careful, but no, don't put a blanket restriction on yourself. Know your body, know your labs, and follow along. Know your medications, things such as that. Vascular calcification. So if your phosphorus is high, if your FGF23 is high, you will begin to lay down phosphorus and calcium in your arteries and veins. So what are we going to do? We're going to eat plant-based phosphorus where we don't absorb it. And we're going to lower phosphorus and we're going to lower FGF23. Inflammation. If you are inflamed as a kidney patient, you will also have inflamed lining in your arteries and veins. What are you going to do? You're going to eat lots of antioxidants from fruits and vegetables to lower that inflammation and help that endothelial lining. One thing that we haven't talked about is anemia. Because your kidneys, this is another wonderful thing your kidneys do. They're so important. Your kidneys produce something called erythropoietin. Erythropoietin is a hormone. And erythropoietin leaves the kidneys and goes to the bone marrow and says, hey, we need to make more red blood cells. When your kidneys begin to decline, they won't do that anymore. And so we need to correct anemia. That is going to be more times than not a medical intervention with your doctor, like a medication. So if you see your hemoglobin is low as a pre-ESRD patient, I want you to be an advocate. I want you to say, my hemoglobin is not where it should be. A lot of times doctors will wait until it's very low before they treat. If you feel bad, please speak up for yourself and say, I feel bad and I want my anemia treated. If you're in dialysis, they will definitely treat your anemia. Okay, so that was a lot of science. I've given you a few practical tips, but I just want to talk to you about just some simple things. So one is, if you need them, if your potassium is high and you've done everything else, and it's not your medications, there are low potassium fruits and vegetables. You can still eat fruits and vegetables. Strawberries, broccoli, cabbage, apples, carrots. There's more. These are just the ones I'm highlighting. So find a list of low potassium fruits and vegetables and just focus on those. What about eating out? So let's just talk about some tips there. So in the left side of your screen, you're going to see this little purple cow called Happy Cow. This is an app on my phone, and you can put it on yours too. And it'll tell you, you just put in your zip code, or you can just open it up and it'll say, show everything nearby. And it'll show you every plant-based restaurant nearby. Sometimes, for instance, if you live in Mississippi and you go to the Mississippi Delta, it's going to say nothing found, no results found. So then you have to know, okay, then what can I do? Delis are usually pretty helpful. You can usually get salads there. You can get veggie sandwiches there. Ethnic restaurants like Asian, Indian, Mexican, those usually have plant-based options. The problem with those sometimes is that they add a lot of salt. Okay, so here's the nice thing about salt in restaurants. If you go to a sit-down restaurant like this, you can ask them to produce your food with less salt. If you're eating fast food, that is not an option, because in fast food restaurants, that food comes basically prepackaged. It is what it is. They just warm it up. So avoid fast food. But if you eat at a sit-down restaurant, you can ask. Also remember that much of the salt in food comes in the form of like sauces and salad dressings. So just get those on the side. Now you're going to think it's really weird, but at the bottom, I have a steakhouse. You may be like, okay, you just told me to stay away from animal protein, and now you're telling me to go to a steakhouse. The reason I'm saying that is because steakhouses have sides. So instead of ordering the steak with the sides, just don't order the steak. Just order the sides. Order, a sweet potato and broccoli and corn or fruit or whatever they may have. And so that is another option. Plan, set your system up for success. So people, many times they have great intentions, but their system, they fail because their system is not in place. The system many times is meal planning. Every Sunday, I take bowls and I lay them out all over my kitchen table, and I make salads. So I'll put greens in all of them, and carrots in all of them, and tomatoes in all of them, and just go through. And then I put the tops on them and I put them in the refrigerator. And then every day my lunch is made. I don't have to think about it. It's done. I set my system up for success. You can do that with any meal. Backing up a step, you have to plan. You have to go to the grocery store and make sure you have everything you need for that meal planning. So make a list. Always have healthy food available, have healthy snacks available. If you're on dialysis and it is permitted, bring food with you to dialysis, because if if you're sat there for 3 to 5 hours and you didn't eat anything, when you leave, you're just going to want to go get the first thing because you're starving. So try to bring something, even if they won't let you eat on dialysis, even if you had it in your bag, so that when you leave, you don't feel the need to go to fast food because you've got something right there. That is setting up your system for success. Let's just talk about other things. Sleeping, go to bed on time. Plan things out so that at a certain time you can go to bed. Exercising, get up and move. When you wake up in the morning, have your shoes and your clothes ready. That is setting up your system. I'm going to put on my shoes and my clothes. I'm going to go out and I'm going to exercise. Remember, you're a whole person. You're a whole body and you're worth taking care of. And so everything all works together. Okay, further help. This is my newest book. I want to tell you about it. You can scan the QR code right now if you would like to be able to find this one. It is available on Amazon. However, it's a little tricky. I have 2 books. The first book I wrote was Plant-Fed Kidneys. The story behind that is I knew all of these things. I had worked with all of these people, and I'm sitting in church one day and my pastor says, "Are you holding information that could help people and you're not sharing it?" And I was like, "Well, yes, I am." So I wrote the book because I wanted to raise awareness that, hey, there's all these people out here with declining kidneys and nobody's doing anything about it. And they're not getting referred to dietitians and they're not being told how to help their kidneys. So I wrote the book. It was really for practitioners, but all these patients read it from all over the world. I couldn't believe it. And so they said to me, "We want more practical advice. We want recipes. They're not here." And so I was like, well, that's not why I wrote the original book. So you know what I did? I wrote one for the patient, just for you. Patients also tell me, "I don't cook." Well, you're going to need to cook a little bit. So what I did here is I made every recipe in this book 5 ingredients or less. Now, if you are a fascinating cook and you love to cook, please feel free to add spices to these recipes. I made them as simple as possible for that person that tells me, "I don't cook and I don't want to." Also, every chapter or section is 10 pages or less, because also a lot of people nowadays, they don't want to read a big long book. They just want you to get to the point. So I tried to just get to the point. There are patient stories in here to encourage you. And like I said, Dr. Joshi wrote the foreword. So I hope this helps you out some. Also, I have an 8-week program where I teach tutorials going back over all these things that we talked about. This is really for the pre-ESRD patient. I'm trying to help you avoid the dialysis chair. Why did I do this? A lot of people want to work with a dietitian, but they can't afford it because insurance doesn't cover it very well, which really bothers me. So I wrote this because you know what? Every single person with kidney damage deserves nutrition instruction. You just do. And if your doctor's not giving it to you, or they're not referring you to a dietitian, or you can't afford a dietitian, this is an option for you. It's an 8-week program. It's $80. It's affordable. It's got video tutorials taught by me. It's got recipes. It's got meal planning tips. And this is the QR code, or you can go to the address here for this program. If you want to contact me, if you didn't get any of that and you're like, well, where is it? Where can I find all this stuff? Okay, if you just go to plantfedwellness.com, that's where, that's my website, and all of those programs are there, and the links to the books are there, both for the patient and the practitioner. I'm also on Instagram. If you'd like to follow me there, I'd love to see you there, or you can email me at jen@plantfedwellness.com. Okay, so let's summarize all this up. Plant-based nutrition is appropriate and beneficial for all stages of kidney disease, pre-end stage, all the way through to dialysis. For pre-dialysis, plant-based nutrition slows progression, and we want to do that. We want to keep you out of that dialysis chair. For dialysis, plant-based nutrition improves wellness and reduces comorbidity risk. So if you're a dialysis patient, don't you give up. Keep living your life on dialysis and be as healthy as you can possibly be there. In all stages of kidney disease, plant-based nutrition is preferred for acid-base balance, for lowering inflammation, for gut health, for phosphorus control, or cardiovascular risk. And in all stages, protein needs can be met with plants and potassium can be controlled. So I hope this was helpful. These are my references. Let me see if I can stop sharing here. And I'm back. And so I think we have a hand raised.
Yeah, so first of all, I wanted to thank you for that very informative presentation. I actually wish I knew that a couple of decades ago with my father, but very, very informative. So before we begin with the Q&A, I just want to go over a couple of quick things for the audience so they know how to engage us properly. So we don't take questions directly from the chat. What we do is we use the raise hand function in Zoom. For those that don't know how to do that, in the bottom of Zoom, second from the right, you'll see a reactions button. You'll click on that, and from there, you'll click on the raise hand function. When I call on you, I will state your name and just ask you to state where you're from and to ask your question. And we just ask that people are brief and on topic with their questions. So with that said, we can go ahead and start some questions here. Just real quickly, you had touched on salt, but mostly you're talking about like the no salt, like substitute. I guess it's potassium chloride. Is the reason why? And,
right. Well, okay. You want to limit salt for sure.
Okay, that's what I was going to ask you actually.
Yes, limiting salt. Okay, remember the two main causes of kidney disease are diabetes and hypertension. So limiting salt is going to lower blood pressure, but also even aside from that benefit, just limiting salt, research has shown slows progression of kidney disease. If you're a dialysis patient, remember what I like to tell dialysis patients is that salt and fluid are best friends, right? So you don't want to, when you're a dialysis patient, you come into the dialysis center and you weigh, then you dialyze, and then you weigh. And what you weigh at that second time is called your dry weight, meaning all the water we've pulled off of you. When you leave and you go home, we don't want you gaining a bunch of weight and then coming back to dialysis because that weight is fluid. How are you going to do that? You're going to limit salt because salt and fluid are best friends. So salt is going to make your body hold fluid, but also limit fluid intake. So there's a lot of reasons to limit salt. Most people know a lot about salt, but they don't know about all the other aspects that I covered. So that's why I covered those more heavily than I did the salt.
And is there any correlation between salt and kidney stones, or what's the cause of kidney stones?
Kidney stones have a number of causes. And so the most common cause of kidney stone is kidney oxalate stone. And so even that can be, you can have a genetic condition that causes your body to make more oxalates, or maybe you're not drinking enough water. So your urine is more concentrated, and then those oxalates are getting filtered out and hanging around in a crystallized form in the kidney. So salt, yes, limiting salt can help kidney stones, but the big thing with kidney stones is there's a number of different causes. Get a urinalysis to know what is causing your kidney stone, and then begin to work on things to help your kidney stone. If it is an oxalate stone, drinking more water, eating higher calcium foods, because calcium will bind to oxalate in the gut and keep it from going through the kidneys. But again, there's so many kidney stones. There's a lot of reasons why you may be getting those. It's not just salt.
Great, thank you. So our first question is from the audience is going to come from Liz. Please state where you're from and ask your question.
I'm from Georgia, and my question is for a patient with kidney disease that has salicylate allergies. Do you know what kind of plants? Because I have a good friend that has kidney disease, and she says she's allergic to salicylates, so she can't eat many plants. So I was wondering what I could encourage her to eat.
Gosh, I've never had a patient that has salicylates. Okay, so it looks like if you have a problem, so this is very similar to what we were just talking about with kidney disease. With what I'm seeing right here, the number of foods that you actually need to avoid with an allergy to salicylates are things like blueberries, avocados, mushrooms, cauliflower, coffee. if your friend goes out and looks at foods that are high in that, I bet that it will just be a few. And then go and find the ones that are low, which will probably be tremendous. The thing, if you're not familiar with plant-based nutrition, a lot of times people see it as very restrictive. But if you think about the massive variety of fruits and vegetables that are out there, things, just think about fruits, for instance. Let's name a few: bananas, apples, oranges, cherries, grapes, pears, peaches, grapefruits, kiwi, mango. And then if you think about vegetables, you've got carrots, you've got lima beans, black-eyed peas, you've got kale, spinach, arugula. And so if she will just pull out the few that are high in the salicylates and then just stick with the others, I'm sure that she can find plenty of things to eat that would fit into a plant-based diet.
Thank you.
Mm-hmm. And welcome, my fellow Southern friend from Georgia.
All right, Rita, where are you from and what's your question?
Hi, Jennifer. I am from Long Island, New York. Brilliant presentation. I hope you know that the 2023 KDO QI guidelines are out just a month ago. And if you had a chance to compare between 2020 and 2023, which are, even better, I'm sure. And if you are also recommending Renadil is a probiotic or any probiotic, so that will be helpful. And thank you very much. Steve is amazing by finding you, and people get to hear from you.
Oh, Rita, thank you. Okay, so the 2020 are, they'll update different portions of the guidelines. So the 2020 is the part that's heavily nutrition focused. That's why I focused on those. Renadil, though. Yes. Oh, so with the KDOQI guidelines, there's not a bunch of new changes. What I went over with you is the newest. I love Renadil. I've talked to the man who created Renadil. That is a wonderful probiotic. I highly recommend it. I love probiotics, but this one, what she's talking about, you can go out and Google this. Renadil, Renadyl, is a probiotic specifically designed for kidney patients, and it helps with uremic toxins. And so, yes, I love Renadil. So thank you for bringing that.
How long will you be asking for patients to be on Renadil? Because actually it is being, manufactured by the Indian patient from South India.
Yeah, so you can be on a probiotic indefinitely. Probiotics are healthy. I've taken one for years. So, as long as really even into dialysis, because there's a lot of, when you have kidney toxins in your body, there's a lot of things that go on with the gut. We don't even know them all yet. I'm sure there's going to be more and more and more research coming out. The gut microbiota research is fairly new, as far as research goes, but you don't have to stop taking that. You can keep taking that.
Thank you.
Mm-hmm.
And speaking of probiotics, I've heard different things from different speakers on probiotics, specifically with regard to the research on the endpoints. Like what actually happens when you take the probiotics? Does it actually, reduce morbidity and mortality? Have you seen any research that shows its impact, I guess, specifically on renal failure or on any other health factor?
Well, so, with the gut, the American Gut Health Project, the biggest study, walked away with eat a variety of plants. That was the simple thing that came from that. Eat a variety of plants. And then there was another study after that said, well, that helps with the gut, but eating fermented foods helps with the diversity. So the first thing I would tell you before we even talk about probiotics is eat a variety of plants and eat fermented foods. What are fermented foods? Things like sauerkraut, but kidney patients have to watch the sodium, but you can just eat like a tablespoon of sauerkraut and it's fine. You could eat plant-based yogurts, kombucha, things like that. That's what I tell you to do first. If you take a probiotic, from what I have seen, the research I have seen, it's more of a kind of pass-through bacteria in that it passes through, it provides a good benefit, but it doesn't stay. It doesn't alter the gut microbiome as much as the diet and the fermented foods. Renadil, and I don't have the research off the top of my head, but it does have research behind it helping with some of these uremic toxins. Now, as far as morbidity and mortality, I don't think they have that data, but they do have data with the uremic toxins. And you know what? Even if you help that, I mean, because pre-ESRD and really dialysis, those uremic toxins cause a lot of side effects, a lot of problems. Like people before, if they don't see a dietitian pre-dialysis, they get like a metallic taste in their mouth. They lose their appetite anyway. Things like that, the nausea. And so Renadil will help with a lot of those uremic kind of side effects. But even more than that, the plant-based diet's going to do even better. The Renadil is just like an extra added bonus, which I happen to like.
All right, great. Let's give Monty another shot. Monty, we're going to give you one more shot. Let's see if we can make it work.
Can you hear me clearly now?
Yes. Hey, Monty.
Hi, how are you doing? Good. I'm calling from Trenton, Ontario.
Okay.
I did a blood test as a prerequisite for 2 MRIs on the spine and the brain. And I was told that in the blood test that I had lowered kidney function. But it wasn't considered dangerous because they needed more information to determine whether I had a kidney disease. If they infer from the blood test that I have lower kidney function, is that something to be followed up on or to be worried about? Or is it something that can just happen at some point in time and then goes back to normal?
Okay. Yes, for sure. It is something that you need to get further checked out, for sure. Okay, it depends. Sometimes people have what's called acute kidney injury. That may mean I'm in a car wreck and I kind of had a crush injury on one of my kidneys. I had to be on dialysis for a couple of days, but they regained function and I'm fine. That does happen. If it is something chronic, let's say you have diabetes, hypertension, or some kind of autoimmune disease, that decline, unless you catch it early, is not reversible. If you catch it early, you can usually stop it and it can get a little bit better, but you may still have some damage. So what I would tell you is get that test redone, get a urinalysis to see if you have protein or blood in your urine. And if your GFR is not 100%, is not normal, or you have blood or protein in your urine, I would get with a nephrologist and take care of that and demand that it's taken care of. Because sometimes they'll go, oh, well, it's not bad enough to worry about yet. Well, we don't want it to get bad enough to worry about. So make sure that somebody sees you and takes care of that. And then above all, remember everything you learned today and cut back on that animal protein, eat a plant-based, low inflammation, low acid diet. And hopefully everything will get better.
Well, I'm a vegetarian, but I was in a car accident, a triple about more than a year ago. And can that really affect my kidneys? Could that really have influenced?
It depends on your injuries. I mean, yeah, there's things that, there's certain things like, for instance, there's things that can cause, acute kidney injury if they were crushed in any way or damaged in any way. Other things that cause acute kidney injury would be like if you had some sort of surgery and the blood flow to your kidneys wasn't good for a period of time, they stopped working, you went on dialysis for a day or two and they came back. Another might be you have a tumor in your ureter down below the kidneys that's backing up urine and it damages the kidneys for a second. You fix the blockage and now they start working again. Those are all acute kidney injuries. That is the only time your kidneys ever, it goes away. You don't have to worry about it again. But if it's something chronic, and I don't know your whole medical history, but if it's something chronic, if you have diabetes, hypertension, autoimmune disease, another thing I didn't talk about that everybody in here ought to know is if you have abused non-steroidal inflammatory drugs like ibuprofen, Motrin, any kind of like non-steroidal anti-inflammatory, that can cause kidneys to the point that they're at a place where they don't return. So there's a lot of
Okay.
reasons. I don't know your whole background, but I would definitely get it checked out. I wouldn't take it lightly.
Okay,
Great.
thank you so much.
So, what about raw green vegetables and green vegetable juices? Can they increase kidney stones or problems with kidneys?
Yeah, so I hear that a lot. No, I mean, that is really not good to make because of the oxalates is why people are saying that. And unless you have some sort of genetic condition that's making you like hyperabsorb those oxalates, no, you're going to be fine. If you look at the work of Brooke Goldner, and she is on the panel here of people that are going to present, she works with lupus patients. Another cause of kidney disease is lupus nephritis. And she has had, just wonderful results with green smoothies. I drink green smoothies. So unless you have some sort of problem with oxalates, that's not really the problem. More of the problem with kidney stones is going to be you're eating too much animal protein, you're putting yourself in an acid state, you're pulling calcium out of your bones into your blood, things like that.
Great, thank you. We actually had Dr. Goldner on last week, so yeah, actually she was great. So, so you went into what are kidney stones. So, what are the best ways to avoid them, and what if you have them already?
The best ways to avoid them is drink lots of water and eat high calcium foods. And then also stay alkaline. So you could even put lemon in your water to stay more alkaline. If you already have them, I highly recommend going and getting a urinalysis and figuring out why you have them. And then according to that, there can be nutritional strategies or even medicinal strategies that help you prevent getting more.
All right, great. And what are other causes of kidney problems that you've seen that people can avoid besides the ones that you mentioned that can be avoided with diet?
Mm-hmm. So the other causes, for some of them are not avoidable. Some of them people are born with. For instance, IgA nephropathy is a problem with our immune system, the complement system in our immune system. And so that is usually affects young people, young guys, unfortunately, and can't really avoid that. The same with lupus nephritis. If you follow Brooke Goldner's plan and get your lupus under control, you can probably avoid that. Polycystic kidney disease is a really interesting, also a genetic condition that there are some things you can do with like plant-based ketosis, because if you don't do junk food ketosis and get with a dietitian to do this, but if you do this, it can help some of those cysts not form. So those are more genetic. And then if you really, aside from that, it is lifestyle. So it's obesity, it is diabetes, it is hypertension. I have had, well, let me start with those three. If you're in one of those states, so we have primary prevention, secondary prevention, and tertiary prevention. Primary prevention is I'm healthy and I'm going to keep myself that way, and I'm not going to become obese or get diabetes or hypertension. Secondary prevention is I have diabetes, hypertension, I'm obese. I'm going to get control of this. I'm going to lose weight and get control of my diabetes and hypertension to prevent kidney disease. Tertiary prevention is I now am in kidney failure. What am I going to do to prevent all the other comorbidities and to stay healthy as I possibly can as a dialysis patient? And that can be done. You're not without hope, even if you're here. So that's the main causes. Other things can happen. Like I once had a patient who had gone in for heart bypass surgery, and they accidentally like nicked an artery, and he was bleeding internally and didn't know it. And his kidneys were not getting the blood flow that they needed for a long enough period of time that they failed, which is very unfortunate. Those things are so rare though. Like when I was talking about, like you could be in a car wreck. Some people are born with only one kidney. I have a patient right now who's born with a normal right kidney, but his left kidney is very small. So, there's a lot of reasons over and above and beyond. The main reasons are diabetes and hypertension. And I have had patients on dialysis that say to me, I put myself here. This is my fault. And I'm mad at myself. And you know what? I tell them, I'm like, you know what? Maybe so, but you're here. Let's let that be behind us. Let's move forward and let's be as healthy as we can be where you are. And what can we be thankful for today? And even just thankfulness, can help. I believe your mental affects your physical and your physical affects your mental. And so all those things help if you're a kidney patient. Another thing is that I didn't talk about that we can talk about is if you are a pre-ESRD patient, you're not on dialysis yet, but your kidneys are not doing well. If you begin to get to late stage kidney disease, please go ahead and get a permanent access. You can have that access for 10 years and never use it. It will just sit there. But you never, ever want to start dialysis in a situation where you crash into the ER and someone has to put a central venous catheter in you, because in that state, you have a 50% greater chance of dying in the first 90 days of dialysis with that central venous catheter there. So please, if you are late stage kidney disease, tell your doctor, I want to go ahead and get that access put in my arm, because once you get it put there, it still takes 3 months for it to mature. So
is that a shunt? Is that what it's called? Or
it's called a CVC. It's a central venous catheter. So you'll have two little tubes that kind of hang out here, and it goes, and the bottom of it goes into the heart. But if your kidneys fail and we're in an emergency situation, we have to access the blood. We have to. And so that has to go in there to save your life. But if you're late stage and you know it, you can get that access placed in your arm, or if you wanted to do PD, you can get a PD catheter placed in your belly. That's where you do dialysis at home. And it can sit there for years, and you can be fine with that for years. And then if you ever need it, it's there, and you don't have to get yourself into that emergency situation that's very dangerous.
Great. Next question is going to come from Steve. Steve, please state where you're from and ask your question.
Hi, Steve from New York. What's the difference between that and a fistula? And
Fistula.
What are the advantages of doing dialysis at home as opposed to at a center? Thank you.
What a great question, Steve. Okay, a fistula is the access of choice. That is what you want. In your arm, what they will do is they will fuse an artery and a vein together so that in dialysis, they take blood away from you from one and bring it back to you in the other. That is number one. That's the best. The second would be a graft, where they will put a piece of Gore-Tex in your arm to create kind of the same thing. The graft, though, is not going to last as long as the fistula. You want the fistula. That's what you want. You never want the CDC. Okay, benefits of doing dialysis at home. If I were a dialysis patient, I would do dialysis at home. One is your time. You do it when you want to do it. You can do it at night while you sleep. You can do PD at home at night while you sleep. So PD is peritoneal dialysis. You have a little tube hanging out of your belly, and dialysate fluid goes into your belly. This little machine does this for you all night long. The dialysate fluid goes in and drains out, and goes in and drains out, and cleans your blood all night long. There's no needles involved or anything. The nice thing about peritoneal dialysis is the diet is less restrictive. It's easier on your heart. Usually when you start dialysis, you have something called residual renal function. That means my kidneys are working a little bit, but just not enough to keep me off dialysis. If you start with peritoneal dialysis, you will preserve that residual renal function longer. If you think about in-center hemodialysis, let's say I start in-center hemodialysis tomorrow. Okay, I'm probably going to get a second shift chair because everybody wants first shift chairs. So I have to just get what I can get. And let's say I live in Mississippi and we have bad storms. We have tornadoes. So let's say tomorrow I go to dialysis and there's a really bad storm and the power went out. And so first shift got on 2 hours late to dialysis. And I show up at my appointed time at 11, but they say, I'm sorry, Jennifer, you're going to have to wait because they didn't get on till 2 hours late. So you're going to have to wait 2 hours. So now instead of being here for 3 to 5 hours for your treatment, you're here for 5 to 7 hours. So things like that. Whereas if I'm a PD patient, I can just do it whenever I want. And there's a way that you can do peritoneal dialysis even if the power goes out. If that machine doesn't work, there's a manual way you can do it where you don't have to worry about that. So those are a lot of the benefits. Some people love in-center dialysis though. That is their time to be with people like them. their neighbor that's sitting beside them in the dialysis chair understands what they're going through, and they want to have that conversation. So they actually like it. There's a third treatment called home hemodialysis, where it's just like what you do in the dialysis center, except you do it at home. I would choose that. The machine is called Next Stage. It's a little small machine. And the thing about Next Stage and peritoneal dialysis, the machines are about this big. Let's say I want to, this weekend, I want to go to the beach in Florida. I can. I just pack up my stuff and I go. Whereas if I'm on in-center hemodialysis, I have to tell the dialysis center, and then they have to call to Florida, and then they have to reserve me a chair, and I have to do a whole lot of planning. And then the last treatment, which it is a treatment, is transplant. You can get a transplant. So the reason it's a treatment is because transplant, you will be on immunosuppressants for the rest of your life. So you're treated for the rest of your life. But you do have a lot of freedom. You don't have to do any of those things except take medication. And you can do it one of two ways. You can either get on a donor list and get a kidney from someone maybe who passes away in a car wreck, but people are on those lists for years and years and years. Or you can get a living related donor. Did you know that you can live with just one kidney? So if you have a family member who is a match for you and will give you one of their kidneys, you can get a kidney now. I actually had a patient that I was working with. He had IgA nephropathy, a very young man, but he had an identical twin brother, and his brother gave him a kidney. It was so interesting because they were so much alike that his immunosuppressants could be super low because he wasn't going to reject that kidney because his brother was so much like him, which I thought was pretty fascinating. I had another friend who gave her kidney to her husband. So see, kidney disease is no respecter of persons. That's two people I know personally, good friends, that have had either a kidney transplant or gave a kidney away. So that's all the accesses and all the types of treatments. There's lots of options. If you're getting later stage, have these conversations with your doctor. Plan for your life and plan positively, because you can live a full life on any of those treatments.
All right. Thank you so much. With that, we need to end our Q&A. Just wanted to thank you very much. If we can unmute the audience, please.
Thank you so much. That was great. I appreciate it.
That was a presentation of the